Everybody, and thank you once again for joining us for our Bipolar postgraduate lecture series this new year. I wish you all a very happy new year and a happy Diwali, and we have lined up a few goodies for you in the form of academic lectures. Today, we have Dr. Hema Tharoor with us, who will be speaking to us on bipolar depression, diagnosis and management. And this is a very confounding area in the field of psychiatry. Everybody knows a lot about depression, but bipolar depression is a whole new ballgame altogether. So we are grateful to her for having taken the time out and to be with us and share her insights into this complex disorder. And we are very grateful to Dr. Arun Maravale. We welcome him and we thank him for making the time to chair and moderate this session. I shall introduce Dr. Maravale and then he will take over the proceedings. Dr. Arun Maravale is a professor of psychiatry at the MGM Medical College and Hospital at Aurangabad. He is a president of the IPS West Zone for the current year. He is the joint secretary of the IMA of Aurangabad. He is a member of the MUHS University, a member of the Board of Studies of the MUHS University, the MIHS University, I'm sorry. He is the honorary treasurer for the Indian Psychiatric Society Social Security Wing. He has sent out mailers to us on multiple occasions, so we know the good work that he is doing in that context. He is the ex-honorary treasurer of the IPS West Zone in 2015, 16, and 17, 18. He is an ex-member of the Board of Studies for Psychology at Aurangabad. He is an organizing chairperson of the PGE-CME Committee of West Zone in 2020. He is the organizing chairman of the first NCYP 18 at Aurangabad. He is the organizing secretary of the ANSIPS West Zone at Aurangabad in the past in 2014. He's been the organizing secretary for various midterm CMEs, for various other CMEs at Aurangabad. And he was also the organizing chairperson for the Symposium of the Mind-Body Medicine workshop held at NIMHANS, Bangalore in 2019. He is not just an astute academician, but he is a very warm and endearing person who's always been very accommodative, very open to new ideas, and very encouraging to all the juniors in our field. And we are very grateful to him for having taken the time out of his schedule today to be with us. And I hand over the proceedings to Dr. Maravale for the evening. I'll come back to you at the end of the session. Over to you, Dr. Maravale. Thank you very much for being with us once again.
Thank you, Rashmi, for elaborated introduction. Good evening, everyone present over here. Tharoor madam and rest all students. As you know, bipolar mood disorder is a severely disabling mental disorder. It is among fifth of leading causes of death. If you talk about the lifetime prevalence worldwide, it is around 1%, whereas yearly it is around 0.5%. In India, KC Dubey for the first time surveyed it and found that the prevalence was around 5.1%, not percent, 1 per 1,000, that is 0.5%. Later studies found that it is around 0.7 to 20. So variable reports were there per 1,000. Still later studies over last 12 years found that it is 10 to 30 times greater than what it was previously. If you talk about the cost, it's huge, personal level as well as indirect cost, travel and medicines and all that. Even the COVID-19 pandemic has increased the chances of precipitation of the fresh episodes. IPS West Zone is very phenomenal in publishing many books, one of which edited by Dr. Vikas Menon is on bipolar mood disorders itself. It's a very nice book. You can go through that. Coming to today's speaker, who is a very renowned person, Dr. Hema Tharoor. Hema Tharoor is a senior consultant at SCARF and Apollo Spectra Hospitals. She has over 24 years of experience in the field of psychiatry. Dr. Tharoor has received Dr. TMA Pai Gold Medal for Excellence in Medical Research and completed NIH Fogarty Postdoc Fellowship in ADHD at Washington School of Medicine. She has contributed to other awards such as Dhruv Kumar Award for the best paper in psychotherapy twice. Dr. Tharoor has over 45 publications in international and national index journals and has co-authored many chapters in books on psychiatry. She is an LGBTIQA plus affirmative mental health professional and has a large practice in clients from the community. So with this brief introduction, I request Hema ma'am to take over. Thank you.
Good evening, all of you, and thank you, Dr. Arun, sir, for those kind words, and Dr. Rashman for giving me this opportunity. And I think this, I think it's an apt time. I think all of us clinicians would agree that we end up seeing a lot of patients around this time of the month, in the sense November to January for postgraduates listening. Even though the classic seasonal that people talk about in the West, we also see a lot of seasonal depression. And I think it was an apt moment that we're doing this talk. Just give me a minute. I'll just share the screen so that you guys can. Is the slide visible?
No, ma'am, we can just see you. We don't see your slide deck.
Oh, 1 second. Is it visible?
Yes.
Okay. So I think the next, my lecture would be focusing, especially keeping postgraduates in mind, highlighting tips that I think all of us should sort of look out for when we see somebody with depression, and to sort of understand if this is bipolar. So a few statements I want to make, looking at literature and from clinical practice over the years, that 60% of adult patients with bipolar disorder who have been found to be misdiagnosed and were actually initially diagnosed as unipolar depression. And out of the 50% of them in bipolar disorder, always, if you go back to the history, they'll talk about having experienced depression at the onset of their symptoms. Say, where we would have routinely called it as moderate depressive episode with somatic symptoms, started them on an antidepressant. Invariably, this could have been a bipolar depression, which we would have missed. 50 to 60 of them also experience an onset during childhood or adolescence. So many a times in practice, I like to ask when I see adult people, around, usually exam anxiety is a huge stressor. So many of them would report around half yearly or around their final exams where and many of them would report saying like they were obsessively worrying about exams, had some somatic complaints. Um, I've had a lot of college students talk to me saying that, some of their semesters, they would recall that the whole November to Jan period was dull, and then they noticed that their mood picked up rest of the year. So just to tell you, please probe, even if you have an adult coming into your clinic, ask for this adolescent onset, which is missed, which would have been untreated. They would have, and if you sort of give them highlights like important life events like exams, to bring them to their attention, they would always sort of accept that they had a episode then. Definitely, as we all know, antidepressant monotherapy is what is described in 50% of people, twice more often than mood stabilizers. So if you look at rest of the pie chart, you do see additionally. So in that very rare where people have teased out the life chart, like, and then very, very rarely do you see that somebody comes in with a first episode depression. It's seasonal. It has all the elements of bipolar written on it, and people have been given a mood stabilizer. So just keep this in mind that very often our first go-to drug ends up being an antidepressant. So there is an International Society of Bipolar Disorder working group, especially on bipolar depression. And again, a call out to all the PGs listening in to just focus on this. So if you have somebody coming in with depression, just look for any family history of bipolarity. Is there a depression reported less than 25 years of age? Is there a lot of, increased hypersomnia, hyperphagia, the atypical features of depression, psychomotor retardation, any symptoms suggesting guilt, and the classic diurnal variation? They will talk about mood either being, worse typically in the morning and towards evening, feeling slightly better, and or the opposite. So the classic lability and diurnal variation of mood. Very, very important is this. I want to spend a few minutes here. Is how would you differentiate it between unipolar depression? You have a lot of people coming in with bipolar depression. So remember this, the duration of the depressive episode will be shorter. There will be an adolescent or a more frequency of depressive episodes in the bipolar depression pattern, seasonality, postpartum. To share with all, yesterday I had a lady brought to me 2 months of depression. They've done the magico religious. Even they told me, interestingly, they said they met somebody, they've been undergoing counseling. They were made to listen to music, meditation, nothing, no improvement. And she had all the classic signs of bipolar depression. And then when I was asking the history, she said she dated it back. So this is yesterday. So we are in November. And she talked about her marriage was in October, first episode in November 97. Delivery was in December of the next year. She had a postpartum. And this is the third episode, and she's 40 years of age. So I'm saying that go back to history and find out about past history and the episodes. Postpartum in women being very, very important. And generally with postpartum, probe a little further, because postpartum depression is either sort of denied or normalized. So you have to ask the symptoms. Multiple antidepressant failures, non-response to antidepressant, or a rapid, or the switch that we see, or sometimes a lot of, like, where the person was given fluoxetine and there is a lot of agitation and insomnia. I already talked about family history of bipolarity in my previous slide. Again, sometimes there's a huge personality overlay also, where, and additionally, there is the overlap of substance use, where a lot of time you would get the person in a depression with bipolar features, and the person saying that he's been fine but started drinking, where to overcome the depression. And we all know classically, if you have a dipsomania or alcohol is used to relieve depression, then think of bipolar depression. There is also this concept of the major depressive disorder with subthreshold hypomania, which can become a BPD over time. So this was, again, very interestingly, work looked at 550 patients with MDD, and they, to just this slide was highlighted to show all of you how nearly 20% of them converted to bipolar disorder in their lifetime. So always remember that not to miss out on these signs when you see somebody walking in with depression. Now, just to summarize this before I go into a lifespan approach in diagnosis, this is a consensus recommendation of AD use in bipolar disorder by the International Society of Bipolar Disorder Task Force. So always rule of thumb has been that when you're going to give antidepressant, and if you decide to give, always remember short duration, watch for switches, keep in mind. So the moment you've recognized that, hey, this is not unipolar, this is more of bipolar depression, always keep in mind that you're going to give it for a short duration. So this slide basically gives you on the left-hand side about when to use adjunctive antidepressant for major depressive disorder. So yes, in bipolar 1 and 2, if there is a history of positive response for antidepressant, make sure that, if there is too much of psychomotor agitation, rapid cycling, like I keep saying, to keep in mind switch. And we all know about bupropion being the drug with the least switch, but sometimes when they come to you with depression where you feel bupropion is not working, and you try and seniors here can comment later post my talk, but I've witnessed switch with venlafaxine, fluoxetine, sertraline. So keep in mind when you're adding the antidepressant and not to continue. So this slide sort of wanting to tell you all about TCA, SNRI switches, AD use in mixed states. Again, if you look at the right-hand side, it is very, very important to keep in mind that when you're using it, the moment you see the manic symptoms coming up, you have to stop the antidepressant. And that's pretty much why I've sort of highlighted this slide. And about maintenance treatment for antidepressant, remember that only if there's a relapse, like after you discontinue, again, you see a retardation. And if you find that there is a recurrence of the depressive symptoms and previously responding better to your add-on antidepressant, then you think of continuing. So what do we do if somebody comes with bipolar depression? Rule of thumb has been antidepressant monotherapy is not recommended, to keep that in mind, like I just reiterated in my previous slide. I've been lucky enough to be trained in Manipal, and I think most of us have heard of Dr. Sharma. And lithium has been, like I said, even this lady who I was recounting yesterday, I've started her on lithium. So if you have somebody seasonal mood disorder, you're very clear it's bipolar depression, there's no doubt to give lithium, please start lithium. I have extensively used lamotrigine, but keep in mind, Stephen Johnson, you must explain about the rashes. You have to start low, optimize it slowly. Also explain to the family about potential, from a rash to an exfoliating reaction to Stephen Johnson. You need to explain about side effects with lamotrigine. So remember that, of course, if the bipolar depression is severe, like somebody comes to you in catatonia, very suicidal, there is no doubt in it about thinking about ECTs. There's a lot given about, lot of literature talking about interpersonal therapy, CBT, now mindfulness-based CBT. But again, our population, depending on, I won't say like a majority, like depending on where you're sitting. So I have I'm fortunate enough to have a mixed bag of both the rural, urban experience. So even then, psychologically minded people, additional support in terms of psychotherapy after the symptoms are in, partial remission is warranted. And in psychotic features, you must add an antipsychotic. Now, what happens if somebody is not responding to your first line? Like I said, adding on lamotrigine, bupropion, sometimes when there is a lot of obsessive symptoms, like I said, SSRI switches common. But depending on the obsessive symptoms, out of the SSRIs, there's been, again, a lot of reports talking about the use of escitalopram. So sertraline, fluoxetine out of the SSRI in terms of switch, paroxetine also. But there is, just keep in mind that bipolar depression the person can report of a, like recently I had somebody who was talking about a lot of aggressive obsession. So when the obsessions are there's a lot of aggressive obsessions in the symptomatology. This person was on lithium, still reported in the background of lithium, I did try paroxetine. So just to highlight that. Newer antidepressants, venlafaxine, when I was a postgraduate some 25 odd years ago, we did have some MAO inhibitors with us. Now it's come back, but not using it these days. But remember, if there's a breakthrough episode, you must optimize the maintenance medication, look for switch. And remember that if you're using antidepressants, you must make sure that you keep in mind that it can worsen the outcome. All major guidelines, I mean, I'm not choosing any specific, so including the IPS, advise the use of mood stabilizer and recommend only AD second in line with the current mood stabilizer. So always keep that in mind. There's always the thing about use it for a short duration, early discontinuation. Frankly, there's very inadequate data saying this is the best antidepressant over the other. But at the same time, there is no strong evidence to avoid them in severe bipolar depression. Of course, we all know about APA guidelines and other talking about the olanzapine fluoxetine combination. So the point here is that to, again, under the cover of an antipsychotic, when this combination has been given, I recently remember in a meeting where somebody was talking about whether that whole idea of giving olanzapine fluoxetine was pharma driven. But I want to say that in overall, the guidelines talk about giving olanzapine fluoxetine combination as a treatment of choice in severe bipolar depression. So I thought I'll do a lifespan approach and then end it with a summary of what I talked in the first introductory slides. So let's start from children. What do you do when a child comes to you, and how do you sort of tease out bipolar symptoms in children, bipolar depression? Remember, if there is an acute or a dramatic worsening of ADHD, where you've sort of thought that the child is ADHD, there is a lack of response to stimulants. And the other clues are where there is grandiosity, inappropriate sexual behavior, severe mood swings, significant aggression, belligerence is talked about in mixed features. In adolescence, euphoria is not so common. Again, to share with you all, it was pre-COVID. I had a 14-year-old who was brought to me. Here, there was a family history of bipolarity, the father taking lithium, this child again on a stimulant, pretty much all these symptoms, and he's responded excellent to lithium. So just wanted to share with you all that with children, keep in mind of these features. So to summarize, in children, mood elevation, mood drops, mood fluctuation, anger, rage, you could get academic issues, physical complaints, fast forward talking, thinking, suicidal tendency. And now with this whole social media, online classes, children's behavior, sometimes it's hard to sort of tease out. But when you have you can always ask the family, and if there is a standout in all these symptoms, think about, is this child going through a bipolar depression? Again, not to ignore comorbidity with pediatric and adolescent bipolar disorder. ADHD is as high as 40 to 90%, conduct disorder 30% to 75%, substance use, and anxiety coming up to 30 to 40%. So remember about comorbidity and keep that in mind. There is also this mood disorder questionnaire, the parent and adolescent version. It's a Medscape, recent Medscape publication, which is sort of helps you in teasing out the symptoms. The treatment issues, I think, in pediatric bipolar depression is, starting and watching out. So again, with children and old people, the rule of thumb, start low, go slow, unless the person is very aggressive. Again, in depression, lithium, bupropion, SSRI to the mood stabilizer, considering lamotrigine, and if there's comorbidity, to keep in mind to stabilize the mood first, and then, because you all of us know that stimulants can sort of worsen the mood state. Again, there has also been, talk about how long to maintain the person. 1 to 2 years should be, again, depending on the severity of the episode, you need to continue the drug for a year or more, and then consider careful tapering of the medications. There is now, over the years, dialectic behavior therapy being tried in adolescent bipolar disorder when compared to treatment as usual. This was study again looking at teens receiving DBT, and teens who attended more therapy sessions experienced less depressive symptoms and 3 times more likely to experience reduction in suicidal ideation. So with adolescent bipolar disorder, one of my alumni from Manipal, she has recently also been trained, and she was talking about DBT in bipolar disorder and in adolescent depression. Again, percentage of people meeting the criteria in bipolar disorder with anxiety, again, in children. So just giving you all this to understand OCD, PTSD, GAD, high level of comorbidity. So to just keep that in mind. And always when comorbidity occurs, sometimes it's confusing. So just keep in mind that substance use, again, Western data talk about very early exposure to substance, the cascade hypothesis. Weed has now become a very socially prevalent menace. Many people would say it's a boon, but I think substance use is a huge factor to also look at when you have adolescents coming to you. Even Chennai being allegedly, quote unquote, a conservative city, I see a lot of high school children reporting of very early exposure to weed. Comorbid conditions also, again, remember, can mask them, because when you see the substance use. So like I talked about the hypothesis of use of antidepressant to cope with depression, it's very, very important to look into that. Again, I want to touch upon, and because I'm leading with adolescents and going into, to watch out for the borderline personality disorder and bipolar depression. Impulsiveness is an important, very important aspect of both, bipolar 2, like the bipolar depression, and comorbid borderline personality. And here, a huge role for oxcarbamazepine and flupentixol, and flupentixol playing a major role with self-injurious behavior, suicidality, anxiety, and I still extensively use this combination. Want to highlight substance use, bipolar depression, and epilepsy as across the lifespan. Again, remember that with substance use and bipolar depression, there could be higher rates of mixed states, rapid cycling, aggression, suicidality. Lithium is a non-responder. So while I did talk about seasonality, lithium, remember, if there is clear-cut substance use, not just during the episode, but there is a comorbid substance use, lithium is not the drug of choice. And also looking at non-adherence, especially in this population. Here, interestingly, there's a greater risk of alcohol comorbidity in women with bipolar depression than in men. And we all know about the telescoping effect, where women develop liver-related issues much more faster than men. Epilepsy and bipolar depression, please watch out for levetiracetam-induced mood changes. Now, levetiracetam, I don't know, in Chennai, it's now the newest, all neurologists love levetiracetam. But please keep that in mind when you see somebody referred to you. Is the person on levetiracetam? And sometimes that is missed, especially when they are referred saying that they have mood changes and depression. So this is again from Epilepsy and Behavior, talking about sleep patterns on levetiracetam-induced mood changes. And also, parallelly, I just wanted to say the contrast where levetiracetam in the management of bipolar depression was also being used. So I just wanted to highlight here that to just keep in mind, if you see somebody is brought to you on levetiracetam showing totally opposite behavior. Just wanted to highlight, there's a lot of talk about protein kinase the PKC inhibitor association with in bipolar disorder. And we have now a new molecule called endoxifen, which is a direct PKC inhibitor. And in the last year and a half, have got plenty of experience in using PKC, especially with, again, bipolar disorder, mania, mixed state. But I wanted to highlight here, especially substance use and bipolarity, with endoxifen playing a huge role in reducing craving. And most patients sort of talk about how there's a reduction in overall mood, that mood agitation is better. Again, dysphoria is better. So just wanted to highlight that. So because it's a direct protein kinase inhibitor, it's like as if you're using your remote and pressing the pause button. Overall, all these guidelines, I wanted to say that I've sort of taken and presented it for the students from looking at this and what's relevant for our talk today. And all of them talk about this. Lithium having modest effects. I'm talking about bipolar depression here. Divalproex, one study showing modest effect size, olanzapine, one, lamotrigine, quetiapine, olanzapine, fluoxetine combination, each talking about robust effects, but mood stabilization not yet demonstrated. I would like to hear from our seniors here. Quetiapine, personally, I have found our population not tolerating, like abroad Western literature talks about doses anywhere 400 to 800 range. Most of our patients cannot tolerate it, and most of them report about excessive sedation, side effects. So to keep in mind that if you're looking at, again, mood stabilization and maintenance, this olanzapine, fluoxetine cannot be continued because it's, we all know that patients do relapse if you only continue them on that. So what is this algorithm talking about? So if you all can look at the bipolar disorder person coming to you, stage 1, let us say the person has, presented to you with depression. So this is just to say that if the person has had an history of mania and coming to you with a bipolar depression, you continue that, you can add on lamotrigine. No manic history, again, first episode, lamotrigine, if people haven't, are so on the right hand side, if you look at it, OFCs, olanzapine, fluoxetine combination. So all the guidelines together, this is the algorithm. Again, this is specifically taken from the International Society, which talks about lamotrigine as a choice. I must admit, sometimes my go-to would be an olanzapine fluoxetine combination first. If I think it is the first episode, no seasonality. And again, partial or no response, consider quetiapine. Again, go down further. You can augment with, again, lithium, lamotrigine. Like I said, look for substance use. So what is approved for bipolar depression? The olanzapine fluoxetine combination, single modality, quetiapine, lurasidone now as an adjunct to lithium. Lurasidone and lithium, lurasidone again, 20 mg working very well in our population, and divalproex. The overall effect size for all these 3 treatments in mitigating depressive symptoms is very similar. That's what I wanted to highlight here. There's no saying that one is greater than the other. Just wanted, because I know it's postgraduates, I'm just giving significance to some latest work. One is the Boulder study, which is bipolar depression 1 and 2, and the Embolden work looking at efficacy of monotherapy quetiapine in bipolar depression. And all of this were 8 weeks. Like I told you, doses of quetiapine being 300 and 600 mg. And the Embolden work is saying that quetiapine was more effective than lithium in improving MADRS scores. And there was low incidence of emergent mania. A big request here, because all of y'all are young minds, is while you read the research, also look at when you're in day-to-day practice, sometimes do I find, I mean, again, I would request seniors' opinion also on this quetiapine tolerance, like the 600 mg, have I given to people? No, where I've even more, when you maximum maybe a 300. More than that, when it's been given, I've found a lot of people not tolerating it. So, and keeping in mind, so it has to be where you're looking at tolerability, not just going by the dose is prescribed. See how the patient can tolerate and watch for side effects. Again, the sequel study was looked at for comparing quetiapine plus versus lamotrigine versus quetiapine in bipolar depression, and talking about quetiapine being, having a substantial adverse effect, more efficacious. Lamotrigine is also very well tolerated as a monotherapy in bipolar depression. Prevail was a program done to evaluate the antidepressant effect of lurasidone, where they looked at Prevail 1 and 2, looking at bipolar 1 patients who had, were started on with depression. And again, compared to a placebo arm, the lurasidone was associated with superior rates of response. Pramipexole, so I'm just going to talk about agents that have been tried other than what was described as in the earlier slides, where we all know about pramipexole being an agonist dopamine receptor. And overall, this is the first report talking about patients with bipolar depression having an increased, it being well tolerated and not associated with hypomania or mania. Modafinil has been used again for acute bipolar depression. Again, like I said, it's diurnal variation, people reporting of early morning severe psychomotor retardation, can't wake up. Again, add-on modafinil can help. Ketamine now, the most favorite kid on the block now. We all know it's an NMDA antagonist, targets glutamate. We have ketamine, spray. Again, I've used ketamine. I continue to use it again, when patients, especially depression, suicidal risk. So meta-analysis studies have also shown that it is efficacious and onset is, been maintained. As far as 3 months, I would say, have witnessed relapses after 6 months. Bright light therapy, just for academic interests. I've had people who've gone online, Amazon, ordered the light, no change, and then had a drastic improvement with, and we all know the kind of bright light that is available online is not the light therapy that has been recommended. And again, especially with seasonal winter depression, Europe and North America talks about this. RTMS now, neuromodulation, being used for, depression. And I think we'll probably in a year or two, Nimans, Ranchi and Manipal are in a collaborative work looking at efficacy, long-term effects. But right now, whatever data talks about, like there have been reports to say that there is an improvement. Some reports talk about placebo response, 30 sessions. So, but I wanted to just highlight neuromodulation's role. TDCS again, with pre and post TDCS showing effects in bipolar depression. There's also a role for nutraceuticals in the treatment of unipolar and bipolar. NAC, N-acetylcysteine, antioxidants, where we have moved beyond the usual networks and neurochemicals and looking at the role of antioxidant. And this was one paper that I found where the effects of NAC on suicidal ideations in bipolar depression again. Psychotherapy, didn't want to end this talk without highlighting the role of mindfulness-based cognitive therapy, interpersonal social rhythm therapy. Chennai has 2 solid support groups run by patients, actually, one of them, and very successful support group for bipolar disorder, and would love to sort of hear from seniors about this. A quick thing on elderly. Remember, depression usually precedes mania by 20 years. Generally, you'll see the elderly person coming to you saying, we know this looks like mania, but again, in elderly, please make sure you roll out, is it a subcortical dementia? Is this Parkinson's? Before you just say this is an independent mood disorder. and most likely to have irritability, treatment resistance, and higher mortality rates. Major points again, please look at physical comorbidities, cognitive impairment, very, very important. Pharmacotherapy, again, the rule of thumb, like I said, with children, start low, go slow. I have a very sweet, I have 3 people actually now, 2 in their 80s and one just entering 90s, but been a very good responder to lithium. Like lithium given years ago stopped, and they're all on 150 mg and no other. I mean, they were given valproate, no response, very severe, elderly with very severe agitation, but just on lithium, doing very well, and they're, again, monitoring their renal functions and everything. So just keep that in mind, that with elderly, start low, go slow. Also, clinical consideration in older adults, please remember the bipolar manic symptoms may be reduced or attenuated. Depressive symptoms, the bipolar depression may be more prominent and exert longer impact. Cognitive deterioration may occur over time. Hyperammonemia is a huge side effect that's missed when you give valproate, so please keep that in mind. Hyponatremia is very, very common too, so that also, and just make sure that medical comorbidity is very extensive. So there's also, I just wanted to highlight, like, looked at the lifespan approach, looked at children, personality, comorbidity, elderly, treatment-resistant bipolar. Always remember somebody coming with recurrent RDD, treatment-resistant, you're thinking it's, so this could be bipolar. There may be an incorrect diagnosis, incorrect recognition. Patient could be a poor historian, poor compliance, check for alcohol or other substance use. Could be, they all come with one whole bunch of prescription, but for all postgraduates, keep it aside. The patient is your best historian. Sit with them, get the detailed life chart. Always ask, like I asked about pointers, seasonality, postpartum, is alcohol used more when they're depressed? Is there been a, because it's chronic and recurrent, have you failed to recognize the bipolarity? And general do not change more than one medication at a time. Remember, you have to prioritize. With bipolar depression, there's a lot of anxiety. Use of benzodiazepines sometimes helps extremely well. Consider cost. Always remember that, you individualize patient care, have a shared decision making, know about the molecule. See, like when you start lithium, you must make sure that by day 5, steady state level, check for blood levels, yearly monitoring of lithium. All this is very, very important. And now with valproate, a lot of patients talk about weight gain, hair loss, and thanks to Dr. Google, please make sure that you explain a lot to the patients. So I wanted to just put up one slide to highlight the different, so if you can just focus on the middle, this is again proposed guidelines in the 3 major phases. And if you look at bipolar depression, so this varies. So this is again from the Florida guidelines, CanMed guidelines, but because if these come up, I don't want postgraduates to be confused. West talks a lot about now lurasidone, quetiapine, FDA approved, lithium, asinapine. I really don't find asinapine as useful as it is put up here. Aripiprazole, anticonvulsants, antidepressants down in the list. I think we covered light therapy, neuromodulation, ECTs, yes, and now the ketamine and the vagus nerve stimulation. Just to just show you that there's also a Florida algorithm for acute depression, which talks about quetiapine, lurasidone monotherapy. Again, postgraduates, not to be confused. Here, this study, this algorithm talks of level 1 as quetiapine and lurasidone, level 2 as olanzapine and fluoxetine, and again, going down to lithium and a combination of both. And if these two are not okay, go to ECTs and then go to the augmenting strategies that we talked about, pramipexole, modafinil, and neuromodulation. Provisionally for integrative treatment, if you look at the depressive phase, I did talk about nutraceuticals. There's also, along with this, talk about omega-3 and NAC. So I just wanted to give you all also a reference to the complementary medicine that's been touted in guidelines. So to conclude, please keep in mind that antidepressants in bipolar disorder is not established. Switches, keep in mind. Again, when I use the strong word like contraindicated, if it's absolutely necessary, give it in severe depression when mood stabilizers have failed, but withdraw it after a short course and after the recovery of depression, and maintain them only in those who seem to relapse. So about 20% of them. Major challenges in the long-term management and preventing the depression, and try use stabilizers that work from below without destabilizing. That means like something like lamotrigine, you start low, build it up. And lamotrigine, really, it'll take about 6 to 8 weeks to get that optimal dose of 200 to 300 mg. And you must tell the patient, if you wait, you will see the response. Most of them talk about, all guidelines talk about avoiding antidepressants. And lithium, again, I must admit, a big fan of lithium. So lithium is still an important drug. And it's again, if you have somebody who's suicidal, also lithium is very good. And we all know about lithium's antidepressant efficacy. So to conclude, mistaking bipolar depression for unipolar is very common. You must focus on history of objective behaviors associated with mania before looking at it as just, hey, so there could be a past history and sometimes it's missed. It could be a hypomanic episode which is missed. And look for features that are very typical of bipolar depression and comorbid conditions. So I wanted to, I think since there are postgraduates here and they all love acronyms, I thought this would, if you could remember, as whiplashed. So forget all my previous slides and just remember this. Is it this bipolar depression? Is somebody worse or wired when taking antidepressant? Is there hypomania, hypothymic temperament, mood swings in history? Is the person irritable, hostile, or mixed features? Is there psychomotor retardation? L for a loaded family history of bipolar illness, affectivity, and mood swings. Is there an abrupt onset and termination in less than 3 months? Again and again highlighting, please ask for seasonality and postpartum depression, hyperphagia or hypersomnia, early age of onset, and lastly, delusions, hallucinations, and psychotic. So to sum it up, whiplashed, if PGs can remember. And thank you for a very patient listening.
Thank you, Tharoor ma'am, for excellent deliberation. Before I comment, I apologize for one slip of tongue regarding prevalence. It is definitely increasing, but not to the level of 10 to 30%. I wanted to comment it on suicidality. It is greater in bipolar by 10 to 30% compared to the general population. That I wanted to say that time. So you have covered the topic very nicely. You have covered risk factors, the factors suggesting bipolarity, then the clinical presentation itself, and use of antidepressants, mood stabilizers, as well as antipsychotics, as well as some adjuvants. I liked your approach, I mean lifetime approach to present this one, right from childhood to old age, the presentation and management. Some comments you said regarding 2 drugs. One is quetiapine and another is this Zonalda. So my experience about quetiapine, we do use in mania up to the dosage of 600. Our colleagues particularly, not me. I go generally up to 400, beyond which I hesitate. But I have seen that it works in mania. In depression, we don't have any more experience. Again, talking about Zonalda, endoxifen. So what I see, it works as an adjuvant either, or in some cases wherein there are contraindications for other mood stabilizers, like you stated some side effects of particularly lithium or valproates or even the carbamazepine group, it's oxcarbazepine particularly. So when the side effects are not allowing us to use that molecule, in that case also it works wonderfully. I have seen at least 2 cases wherein it worked very well. But I have reservations about mood disorder with drug abuse, particularly alcoholism, because it's not much useful in such cases because my experience is limited. But wherever I have used in comorbid alcoholism, it has not shown much, benefit. There are seniors like Rashmi, Jyoti, and Jay also. So I hope they will also have some comments regarding this. So I declare that this session is now open for question, answer, and comments. Thank you.
Thank you, sir.
If any questions are there, comments are there, particularly the senior Jyoti, Jay, Rashmin, and if questions are there from students.
We would encourage everybody to put their questions up in the chat box, just so we can access them also for our records, as well as for us to have a more organized discussion.
Yes, if you are not able to ask directly, you can have it in chat box, the questions particularly. For comments, you can directly talk by unmuting the mic. Yes, Jay Shastri, any comment?
Maravne, there are some posts in the chat box. If you can just access the chat box.
Chat box. Okay. Actually, I am not able to access it. So will you please read?
Okay. Dr. Amit Upsham has mentioned that he was quite appreciative of the session. He said a very lucid session. Dr. Jagjot has put up a question to Dr. Tharoor. How to manage a patient of bipolar depression who doesn't tolerate antipsychotics?
Yeah, that's a tricky one. See, honestly, if you ask me, when you say does not tolerate, it'll be nice if you could, like if it's a specific, like if you're saying somebody, when you say don't tolerate, if you can explain that a little further, because if you think the person has psychotic symptoms and needs antipsychotic, and if he's not tolerating at a certain dose, try lower dose. If he can, all drugs, all antipsychotics he won't tolerate, then you'll have to look at the other gamut of drugs that you have in terms of benzos with the mood stabilizer. Or so just when you ask me won't tolerate, what do I do? And many a times when clozapine in a very low dose helps as an anti-suicidal. So again, I didn't say clozapine immediately because that doesn't solve your question. You asked in general if they don't tolerate antipsychotics. So yeah.
Now I can see this chat box.
He asked specifically that what do we do with the sedation that you might encounter with olanzapine and qutipin or both?
So initially, oh, sorry, let me. Oh, I didn't see that. Sorry. So that's why I would agree with Dr. Arun. I've not in bipolar depression in specific. I've also encountered a lot of sedation with. So then I go down. So the olanzapine fluoxetine combination, then you end up giving half the dose. So you have to look at tolerability, and if the person feels extremely sedated, invariably then the person becomes non-adherent. So that's why it's very important to reduce it and, try. And then if you think that they're not, half dose is not enough for treatment response, so it's a fine balance between response and tolerability, then switch to lamotrigine or other drugs rather than going for the olanzapine fluoxetine combination. Same, I would give the similar answer to the quetiapine.
Okay, Dr. Madhav Raze has asked one question. Would you explain on impulsivity and bipolar disorder in bipolar disorder?
So I was trying to highlight where like an ADHD in a child, or again, I mean, I'm explaining two things: ADHD in a child versus a borderline personality, where you're looking at impulsivity as a huge, issue. And then how do you delineate? So somebody with a bipolar depression could become more impulsive, more agitated, or more spending. So there were two children in the recent past who were brought to me where the parents said that again, there was a lot of he was not like this impulsive buying, ordering a lot on, of course, now all the Zomato, Swiggy. So that was what was typical of the behavior. So you have to again ask the history, previous history, and see how much of impulsivity is reported by the adolescent and in what kind of behavior. So this behavioral addiction is a huge thing nowadays.
Okay, thank you. Dr. Zain has asked one question. If a young female with marked anxiety presents with first episode depression and a few atypical features like retardation, evening worsening of mood, should we give an SSRI and the risk rapid cycling switch or start with the mood stabilizer?
Dr. Zain, so again here, when you say young female, so you have asked this, so I would, if there is no evidence to suggest like what I said about past history and all that, and no seasonality, and you don't want to give the moods, yes, you can. I would choose an olanzapine fluoxetine combination in somebody like this, I mean, from what you have reported. Or if the person is very particular about weight gain, like I have a lot of people who they Google and they say it's a drug for schizophrenia, there's weight gain. But the point is, for the symptoms you wrote, if we start lamotrigine and weighted, you don't get the response you need because you can't hit the dose. So my go-to first will be the OFC, olanzapine fluoxetine combination, with benzodiazepines to help with the agitation that you have reported.
Jyoti Shetty has complimentary remark. Excellent Hema. Then Jagjot has commented on olanzapine and quetiapine about its sedative effect.
Yes.
More sedative effect. Again, a question from Jagjot. Giving SSRI when patient complains of headaches and decreased sleep. So what to do?
So just even I've had this where if you end up prescribing them in the night, so sometimes, so I switch it. I ask them to take, so if I ended up giving a fluoxetine generally I use morning or afternoon, again with, but many of times they forget and take it in the night and they say insomnia. And we all know that with fluoxetine and the other SSRIs like sertraline. So when they reach out, I tell them to change it to a morning dose or a afternoon dose, but insist on post food because most of them don't eat breakfast or lunch, and then it's an issue. Yeah.
About headache?
They give us a headache, sir, when they say headache. So I do tell them that, again, it is because of many of them don't have, I do check if they are the meal timing and taking of the medication, sir. So
Yes.
to ensure that food post that.
Yes, of course. So Jyoti, after complimenting, has a question. Any comments on use of newer antidepressants like corticosteroid, vilazodone in bipolar depression?
I purposely didn't write. I mean, I didn't bring it up because it's the new child in the block. I thought I'll, I have only anecdotal experience, and I didn't want to just say that, hey, I'm giving it in elderly. Yes, I'm trying it in elderly, but I find again, I didn't want to talk about my experience, so didn't highlight it. But yes, I am trying it in elderly. Mixed effects, some of them reporting of nausea, the usual SSRI side effects. But overall, the response has been fair to good.
Yes. Yes, Om Prakash. He has a question. How do we treat first episode depression in second and third decade, which have most features not pointing towards bipolar type depression, but strong positive family history of bipolar disorder?
Dr. Srinidhi, here, if you have if you're convinced it's mostly unipolar, but there's a strong family history, you need to keep in mind that there is a strong, and like, remember one slide of which I said 20% of unipolars can become bipolar later on. So you keep that in mind and treat it like you would treat any person with a recurrent depressive disorder. And since you mentioned it's a lady, to keep in mind, see, 40s is another age when they can have an episode, which looks more like a bipolar. So just keep all those factors in mind.
Actually, my experience in bipolar, but I'm not talking about this question typically. In bipolar disorders, only mood stabilizers may not work. Many times, some patients I have seen, they require SSRIs. Addition of SSRI will improve them. Otherwise, they always go on complaining that there is no improvement. So that is my experience, not given in books. So there are no questions in the chat box now. So if there are no questions, I would like to hand over to Rashmi sir. Rashmi.
Yes. Thank you very much. And it was a brilliant talk, as expected by Dr. Tharoor. The beauty of any discourse is in its simplicity and the way it is possible for us to relate to it. I think on that count, this was as relatable and as lucid a presentation as could be. And a very complicated situation, a very complex issue, but we managed to really convey it in a very, very lucid manner, a very easy to understand manner. And as I said, the lowest common denominator is the deciding factor. So if somebody like me can understand this, I'm sure everybody else would have understood it as well. So thank you very much, Dr. Tharoor, and it was really kind of you to make the time for us. And thank you once again, Dr. Maravle, for having spared the time and chaired this session in a very gentle and a very lucid manner as well. So thank you all for being with us, the audience. We had quite a few senior faculty members as well, apart from postgraduate students. And for the few who probably missed this opportunity to hear her live, this will be uploaded to the website in a few hours from now. So you have the opportunity to revisit not just this, but all the lectures we have had so far on the website directly through the link available under e-speaker's description. And of course, a big thank you to Sun Pharma for their unflinching, unconditional academic support for this endeavor. So thank you all once again. Thank you again, Dr. Tharoor and Dr. Maravle. And I bid you all a good evening ahead of you until we meet again the next month with another very interesting topic. Thank you.
Thank you so much, Dr. Thank you.
Thank you. Thank you very much.